Welcome to the second session. My name is Trip Buckley. I'm going to be moderating with Jen Kolb. We're super excited to have you here. I'm really excited about this session because, number one, I get to throw the jokes about John Lipham, and I'll start with the first one. Raise your hand if you've survived 2 operations by John Lipham. So it's a small group. I've had 2. That's a true story. 2 operations by Dr. John Lipham. So when he was talking about complications, I guess he is the expert. Secondly, I am a surgeon and I have Barrett's. So I've got a lot invested in this. I've got long segment Barrett's, lots of risk factors. So I hope to learn a lot, and we're going to be heading on into this full steam ahead. Jen?
Yes, all right. So we're super excited for this session. This is not going to be your average Barrett's. We're really going to talk about how to push the envelope, what's coming, what's new, and what our experts would do. So we will start off with one audience response question just to get the juices flowing. So if we could get that up there. All right, so you have a 62-year-old white male, longstanding heartburn on PPI, occasional regurgitation, has a screening endoscopy, and you do find Barrett's esophagus, a little bit of esophagitis, C4M6. So what is your sampling approach? And you should be able to pull this up on the Whova app and place your votes. We're gonna get into this, we're gonna talk about this during the session, but just to get you thinking. Are you sampling? Are you using Seattle? Are you using Watts? Are you using them together? Okay. Okay, so keeping that in mind, we're going to start at the beginning of Barrett's, which is how do we detect patients with Barrett's by screening. So I'm going to invite up Dan Lister to start us off.
Thanks, Jen. Trip. Glad everyone's here. I would like to point out, as your president-elect, I had to one-up Felice. While her beautiful dress does have AFS colors, my shirt has AFS colors and my socks. So, Mike, the bar has been set. I am not going to display underwear for everyone's sanity. Thank you. All right, so finding Barrett's, is it time to ditch the scope? So we all know this slide. You know, the SEER database, with all of our guidelines, with all of our technology that we have today, we are doing a lousy job with this disease. You can't look at that curve and go, oh yeah, we're doing great, because it's up over 500% since 1970. It's the second most lethal cancer behind pancreatic, and its 5-year survival is less than, well, it's around 20%. So, and Barrett's screening remains very low. We're very familiar with the risk factors. Of the 46 million patients that have chronic GERD, you go down 1 risk factor, 2 risk factors, on down the line to your highest risk patient, the 50-year-old male with risk factors, and less than 10% of that patient population gets screened. So of the 46 million, we're doing 900,000 EGDs a year. So our traditional journey of at-risk population and scoping, as you can see here, 90% of those patients aren't getting scoped, and they're presenting with advanced adenocarcinoma. We've got to do better. We have to change this paradigm if we want to make a dent in this disease. So I would suggest a new patient journey. We take our at-risk population, we use a non-endoscopic screening method. If that is negative, we're done. We've screened that patient, and we no longer have to worry that they're going to end up with esophageal cancer. If they're positive, then we're scoping a much more enriched patient population, and we can then risk stratify these patients and either treat them properly with surveillance or with endoscopic eradication therapy. So what non-endoscopic screening modalities do we have? The first FDA-approved capsule endoscopy, similar to the pill cam, was used, and they had problems with it at first because of the rate of transit through the esophagus and a low frame rate with the cameras. They ended up missing a lot of Barrett's. As they increased the frame rate, they still found that they would miss up to 25% of Barrett's patients with the pill. I have to say that my talk is now obsolete because as I went through our industry display earlier, there's a new tethered capsule there that eliminates that. So you can hold the capsule at the end of the esophagus and screen for Barrett's using that. At the next break, make sure you stop by the Angst Robotica booth and look at their capsule. A couple others that I'm going to touch briefly on: the tethered capsule microendoscopy. Same principle, a tethered capsule that uses optical tomography to microscopically look at the esophagus. It's effective, but right now it's currently not FDA approved and it's not commercially available in the US. Same thing with the volatile organic compounds, the e-nose, where the patient breathes into a machine and we look for Barrett's. Sensitive, but again, not FDA approved and not commercially available. So I want to spend the majority of my time talking about what is available, and that is cell collection devices with biomarkers. There's two main ones. Cytosponge uses the trefold factor family protein 3. It's a capsule that is swallowed, then the capsule dissolves in the stomach and releases a 30 millimeter sponge that's attached to a string that is then pulled back through the esophagus and cells are sampled. It's generally well tolerated, takes around 10 minutes to do, and it does collect cells from the entire esophagus. There's been several European studies, but I did want to show the US study that showed good sensitivity for both 1 and 2 centimeter segments of Barrett's, as well as good specificity and good positive predictor and negative predicting values. Unfortunately, currently it's on recall, so it is not commercially available in the US. But my understanding is they are working on a new device that does the same thing. So hopefully that will be available soon. The one device that is currently available, the EsoGuard and EsoCheck system. The EsoCheck is the collection device. The EsoGuard is the genetic test that they do. It's a small capsule, as you can see on the left, that is smaller than your average vitamin. It's swallowed once it's in the stomach, inflated, and then drawn back through the distal 5 to 6 centimeters of the esophagus. And it samples much like a pap smear, where the small ridges on the balloon take cells from that target environment that's not the entire esophagus. It's where Barrett's is going to be if it's there. And then the balloon is deflated, where we capture those cells and protect them so that you're not diluting the specimen going up through the upper esophagus, and you're also not adding possible contaminants with nitrosamines from cigarette and tobacco use that could possibly alter your results. This test is then looked at for methylated vimentin and CCNA1. Here's their 4 validation studies that they've done so far. As you can see, a very nice 88% sensitivity, 92% sensitivity in the VA study, 100% sensitivity for esophageal adenocarcinoma, and probably the most impressive for me is a 98.6% negative predictive value. So when you get a negative EsoGuard, you can trust that patient probably doesn't have Barrett's, and you don't have to worry about them. I would like to finish my talk with, the most common pushback from screening that I hear is it costs too much. You know, we can't afford to screen everyone when we're doing colonoscopy. And they looked at a study where we compared doing EGDs at the time of screening colonoscopy, and the ICER for that is $79,000. $79,000 for every 100,000 patient year gained. And anything under 100,000 is usually considered cost effective. But I want to point out a few things here. This is the SEER database projections for this year, 22,370 new cases of adenocarcinoma of the esophagus. The estimated cost of the care of those patients is $18,000 and change a month. So in the past, John has done nice calculus for us on his talks. I just do basic multiplication because I'm from the South. But when you multiply those two numbers together, that's a cost of $411 million a month for patients that have a 20% 5-year survival, and they're going to die a horrible death. And the number that really makes that soak in is that's almost $5 billion a year. So can we afford not to screen? All right, thank you very much for your attention.
Any audience want to come up and challenge Dan? If you're welcome to. Otherwise, we'll have Vivek Kaul come on up and we're going to learn about Beyond the Pinch.
All right. Good afternoon. I'm Vivek Kaul, University of Rochester. What an excellent talk, Dan. I have AFS colors too. This is Pete Carilla's favorite jacket. Is Pete here? There you go. He will confirm that. Do it offline, please. I want to congratulate the outgoing president and the incoming president over here, and the next president, Mike. And thanks to AFS for having me here. Big shout out to Kate Freeman. It is incredibly difficult to organize and effect a meeting of this level. So a huge, huge congratulations. My tasks usually get the end of the day, before cocktails, after dinner, post-lunch talks, so it's true to tradition. My charge today is to speak to another technology that has really been a progressive paradigm in Barrett's and dysplasia detection in the last decade or so. These are my objectives. I want to emphasize a little bit beyond the fact that what Dr. Lister explained, in about 2040, we'll have 1 million cases of esophageal cancer worldwide, with about 850,000 of them who will die. The vast majority of them will be squamous cell cancer, but regardless, these technologies, these paradigms, these platforms, these interventions are going to be equally effective and useful for that subset as well. But our focus here in Americas is on Barrett's. We have a predominance of that disease, as was just highlighted. So I'll show a few challenges in Barrett's screening and surveillance as it stands today in what the state of the art in clinical practice is. I'll discuss a little bit about the CDX wide area transepithelial sampling device, the research on that, the literature, the current practice, and then finish up with some take-home points. So the challenges in Barrett's screening and surveillance are well familiar to this audience, but let it be stated that the adherence to Seattle protocol sampling is extremely poor, even amongst academicians across large health systems and individuals, and I see it on a weekly basis in my own community as well, unfortunately. Sampling error prevails, especially in long segment Barrett's esophagus. There is a significant amount of variability in pathological interpretation, as we know well, and there is also a huge paucity of GI pathologists that are dedicated in Barrett's esophageal evaluation. There's extremely high variability in endoscopy quality, and many documents have been written by many esteemed professionals on the quality enhancement in endoscopy, but the needle is moving very slowly. And then, of course, there is also the issue of interval cancer in esophageal disease, very similar to the paradigm we have in colorectal cancer screening. So these are all the issues that are there, and they're well highlighted in the literature, as you see on these next couple of slides. 2009, the same question around adherence to biopsy guidelines. 2019, the same parameters are being reflected. We are not doing any better. On top of that, we are scoping people more often, and we're not doing a great job scoping them. In fact, a recent review by two esteemed colleagues in our field found that we are possibly missing up to 50% of dysplasia and disease here. So we're doing a lot more sooner, more frequently at a higher cost, but we're not adhering to guidelines. We're not doing a great job. We're quite imperfect at BE sampling, and even if we were perfect, we would not be sampling more than 10% of the mucosa. And the needle hasn't moved in the last several decades. So therefore, we have a problem. And when we have a problem, we convene to look at strategies. How do we move the needle? How do we fix the problem? Well, here are a couple of solutions. We can either improve the endoscopist performance. Good luck. I said that with tongue in cheek, but it does happen, but it doesn't happen to the extent that we would like. Or we could improve technology, sort of dumb down the process a little bit, take automation to the next level, and remove subjectivity, which are all the problems that are highlighted in the first few slides. So there's need for education, there's need for awareness. These type of fora are actually very good to disseminate information, and that's what we're trying to do. Incentives and disincentives haven't really worked very well. The MIPS program, the MACRA program, value-based purchasing, all has come and gone. Unfortunately, COVID had a big impact on those as well, but there's always that to consider as well. But better imaging, newer devices, newer technology is maybe where the answer is. I do want to emphasize that there is some recent documents on the importance of high-quality endoscopic examination in Barrett's, very similar again to colorectal cancer screening. For time constraints, I can't get into that, but there is no substitute to a high-quality endoscopic examination to the tune of about 1 minute per centimeter of Barrett segment after you've cleaned the esophagus and taken your time to look at the anatomy. So what are options? Some of them were listed by Dr. Lister very eloquently. I should say that there is a fair amount of work being done in the volatile organic compound arena, especially in London right now, and that's for squamous as well as for adenocarcinoma. But that's not my topic tonight. AI is being introduced. We are relatively early in that paradigm. Cytosponge and the Tether devices have been reflected upon already. So my charge is to dive a little bit deeper into the Watts 3D CDX brush biopsy sampling platform. So here is that device. This is the CDX brush biopsy catheter. It's basically an abrasive brush. And for those of you who have felt it through preferably a gloved finger, it is actually pretty stiff. It is several fold more stiffer than the biliary or previous esophageal cytology brushes that we were using for candida and for biliary sampling. These are tissue fragments that do preserve some degree of cell structure. They don't have architectural details such as a biopsy would have, but they're good enough for assessment. Then comes the next interesting phenomenon. It is a combination of an AI or convoluted neural network type of paradigm combined with the actual human assessment of a pathology slide, and there is the added element of immunohistochemistry that we haven't quite yet figured out how to put that into clinical practice, but that could be a topic for discussion in the panel as well. So that's kind of the construct, that's the model, that's the platform. These are some high-def images of the brush without and within the scope. This is a standard gastroscope, requires a 2.8 millimeter channel, so it won't go through a slim gastroscope, just as an FYI. The next set of pictures show you the real problem with forceps sampling, which is sporadic, especially if you have a long segment Barrett's, but the advantages that are conferred by a brush sampling device that goes up and down and sideways, as I will show you in this animation coming up next. So basically, you have a segment of Barrett's, and you scrape it up and down. Sometimes with some experience, you can go sideways as well or circumferentially, and you tend to grab more surface area, and that's the premise. In a live human patient, that's the construct. This is not the easiest segment to sample. That's why I showed you that. There are hiatal hernia to be contended with. and so forth. But typically, that's the construct, and we can talk about that in the panel discussion. Then the next step is the sample goes in a kit to a dedicated laboratory in Suffolk, New York, and that's where it gets processed. These are the sequential imaging slides showing how the sample is processed and what it kind of looks like at the end when a pathologist is actually looking at it. So the AI algorithm actually brings out the worst cells up in a three-dimensional matrix for the pathologist to look at, and that's where we go from. So all this is good, but what does the data look like? Well, for a technology that's relatively so young, there is a lot of data out there, and this is my attempt at summarizing it to the best I can, and I will invoke one of the earlier studies here about 5 or 6 years ago from Mike Smith. I was on the panel as well. A fairly large study, 13,000 patients, prospective, community-based practice registry, looking at basically incremental yield in the space of Barrett's, intestinal metaplasia, as well as dysplasia. And these are the what we call adjunctive yield or incremental yield numbers. And the absolute numbers here were also not insignificant. There was an upgrade of about 19% for IM detection, absolute values, 19%, and 2.3% for dysplasia incremental yield, absolute numbers, not insignificant. This was followed more recently by a registry study that was also a fair number of patients, but it looked at a different question. They looked at whether or not it works equally well in short segment or long segment Barrett's. And here are the numbers. Across the board, the incremental yield was quite significant. And when you looked at long segment Barrett's, the dysplasia yield was even more than compared to short segment, which is where we want to be. So quite significant numbers here for that. Dr. Scott Corbett looked at a relatively smaller number of patients compared to these studies, but looked at a very unique niche, which is post-ablation sampling. Post-ablation sampling remains a problem, and we are probably not doing it as well as we should, but this is another adjunct paradigm showing us that you can actually enhance that yield as well using this technology. And then one of the last studies I want to highlight here is a study that just came out this year. This is currently the largest study in this space, nearly 24,000 patients. It's a prospective registry study of screening patients with GERD. This is not an enriched population. But even in a non-enriched population, you have a very significant incremental yield, as is shown by these numbers, 17% absolute incremental yield for detection of Barrett's, and 0.5% for dysplasia. When you multiply 0.5 by 24,000, you get the message. So this is such a rich literature on a device that I'm not even able to get to a randomized, double-blind prospective study done and published in GIE with relatively smaller numbers, which had similar impact. In fact, in the Venn-Lagati study that is listed there, there were 23 dysplastic patients that were found by Watts alone that were completely missed by forceps biopsies. So literature is pretty robust. How about the safety and cost effectiveness? Well, the cost effectiveness numbers were referred to by Dr. Lister as well. It falls below the $100,000 threshold, and it adds about $1,000 to your procedure per kit, so to speak. No major adverse events in the studies, no major adverse events in my nearly 10 years of experience with this. But like anything else in this universe, there's no 0, no 100, right? So there's 2 cases in the MAU database, which basically is one of the few databases in the world that actually captures device-related problems. I suspect that both of these issues were likely anatomy and or operator-related. I don't have further detail on this, but my caveats are that when you have a tortuous anatomy, a large hiatal hernia, you should be careful driving any catheter in that space. Limitations, of course, like any technology, technique, performance, the feedback you get in the moment, the inability to have rapid on-site cytology, relatively limited availability compared to forceps biopsies, the often quoted question around central or proprietary pathology, which has been somewhat mitigated by the fact that many of the studies have had a central pathologist all the way up to the stature of Dr. John Goldblum at the Cleveland Clinic who have ratified these pathologic findings. So I think that's not a huge issue right now. But I think what's a bigger issue I think that we all will contend with is what to do with those patients who have a positive forceps and a negative warts, or a negative forceps and a positive warts. And I think that's the arena where we are going with the SWOT-BE trial, which we are a part of as well. This is the first trial looking at non-dysplastic Barrett's esophagus and actually randomizing them to forceps versus warts in both orders. So forceps first, warts next, or warts first, forceps next. And that study and that question, the answers are still awaited, obviously, because this is a long study that we are still in the middle of. But hopefully this will answer some of these questions, whether or not we can replace one technology with the other. So take-home points from my side. Barrett screening and surveillance is a huge challenge. We have already known that, but I've showed you some information related to that as well. I think techniques to enhance tissue sampling are both in the moment, endoscopic as well as non-endoscopic. Biomarkers, of course. AI might come to help us. But I think right here, right now, we have a tool that is time-tested, has robust literature attached to it. I don't think that there's any question at this time that we have an incremental yield information and paradigm that's in place. But whether or not it can replace, should it replace, can it replace, is it worth replacing? Those are the big million-dollar questions that we have to answer. Finally, in my opinion, for every disease state management, the best outcomes are really between optimal human performance and optimal technological performance as well. Thank you very much.
Great, thank you. So this session is titled The Life Cycle of Barrett's Disease. So we started with screening. How do we identify more people to bring into the group of potential Barrett's patients? How do we screen, survey, and potentially identify more IM, more dysplasia? But then what do we do with all these patients? And so we're thrilled to have Rhonda here to give us a sense of how do we use biomarkers and new tech to help us risk stratify.
Great, thanks. Thanks, nice to be here. Thanks, everybody. All right, here we go. Okay, disclosures. All right, we're going to start with a case, as I was requested by Madam President to start our presentations with a case. So this is a 56-year-old man with chronic heartburn who undergoes a screening endoscopy, which shows a C2 M4 segment of Barrett's esophagus, and 4-quadrant biopsies were taken every 2 centimeters. Biopsies showed intestinal metaplasia without dysplasia. You recommend surveillance endoscopy every 3 years for his long segment Barrett's. But he tells you his friend with Barrett's esophagus was in surveillance and he got esophageal cancer anyway. And he asked if there's anything better than surveillance to prevent cancer. What about biomarkers? Well, the best 2 studied biomarkers for Barrett's esophagus are P53 immunostaining and TissueCypher. So what is their role in improving risk stratification for your patient? So let's start with P53 immunostaining. P53 has the largest body of evidence as a biomarker, and immunostaining is an easy technique that's commonly used by pathologists. Mutations that will inactivate the protein but stabilize P53 show up as overexpression, and mutations that prevent translation of that protein show loss of expression, and together they've been termed abnormal P53 expression. So here's a meta-analysis, systematic review and meta-analysis for risk of neoplastic progression in P53 immunohistochemistry in baseline Barrett's biopsies with follow-up looking for neoplastic progression. On the left, you see 8 case control studies. On the right is 7 cohort studies, and you can see those are the forest plots of those studies. And both case control and cohort studies show consistent, strong, and significant associations between abnormal P53 immunostaining and progression to high-grade dysplasia or cancer. And P53 can be performed on cytosponge samples like we talked about earlier. So in this study coming out of the UK, 223 Barrett's patients who had endoscopic surveillance delayed due to COVID-19 underwent cytosponge sampling as a way to prioritize endoscopy in these patients. So the biomarkers were P53 overexpression and cellular atypia, and they were performed on cytosponge samples. Endoscopy was then performed only for positive biomarkers, and 39 Barrett's patients were biomarker positive. When they underwent endoscopy, 17 of them had dysplasia, and 12 of those had high-grade dysplasia or esophageal adenocarcinoma. And this is a follow-up study by the same group that was presented this year at DDW. So in this study, they looked at cytosponge samples. Patients had endoscopic surveillance using the cytosponge, and they performed p53 immunohistochemistry and cellular atypia. Based on that, they divided patients into low risk, moderate risk, and high risk. And these categories, again, were based on biomarker positivity as well as those clinical factors you can see listed. What they found when these patients underwent endoscopy is that patients in the low-risk category had less than 2% findings of dysplasia and cancer. Patients in the moderate risk group had 3% findings of dysplasia or cancer. And in the high-risk group, over 40% had dysplasia or cancer. When they then dived a little bit deeper into that high-risk category, they found that the biomarkers and not the clinical factors were driving the predictive performance of that group. So another well-studied biomarker is TissueCypher, which uses a systems biology approach for predicting progression. It's performed on Barrett's biopsies. It starts with multiplexed immunofluorescent slide labeling for 9 protein-based biomarkers, which are then imaged via whole slide fluorescent scanning. Those 15 best performing quantitative measures of the biomarkers and nuclear morphology are then imaged using an artificial intelligence imaging platform, which eliminates subjectivity in their interpretation to generate a risk score from 0 to 10, which then categorizes patients into low risk, intermediate risk, and high risk for progression to neoplasia within 5 years. So this is a international multi-centered study of 4 independent case control studies done in the US and Europe with a total of 552 Barrett's patients. The 152 cases were patients who developed high-grade dysplasia or cancer on follow-up. The 400 control patients did not develop high-grade dysplasia or cancer on follow-up. They did a clinical prediction model based on age, sex, histologic diagnosis, Barrett's segment length, and the presence of a hiatal hernia. They found that a high-risk TissueCypher score alone predicted a 6-fold increase in neoplastic progression, and when that was combined with the clinical model, it significantly improved the predictive value of the clinical model. If we specifically look at patients with non-dysplastic Barrett's, a TissueCypher high-risk score alone predicted a 14-fold increase in neoplastic progression and significantly improved the predictive value of that clinical model. And in another study, non-dysplastic Barrett's patients who scored high risk progressed at a rate higher than an expert pathologist confirmed diagnosis of low-grade dysplasia. So take a look at these 268 Barrett's patients. 58 of these progressed to high-grade dysplasia or cancer, and 210 did not progress. Here you can see their diagnosis by this expert panel of pathologists. Patients that had an expert panel diagnosis of low-grade dysplasia had a 3.8-fold increased risk of neoplastic progression compared to those with non-dysplasia, with a positive predictive value for progression of 21.8% over 5 years. Now, if we look at the TissueCypher risk score in the expert pathologist confirmed non-dysplastic Barrett's patients, you can see here that the high-risk score had a 5.1-fold increase compared to patients who scored low risk, with a positive predictive value for neoplastic progression over 5 years of 26%. So somewhat greater than 21.8%, but still greater than an expert pathologist confirmed diagnosis of low-grade dysplasia. But because of the low sensitivity of these biomarkers, the ACG could not make a recommendation on the use of these predictive tools, p53 immunostaining and TissueCypher, in addition to standard histopathology in patients who were undergoing endoscopic surveillance of Barrett's. However, the ACG did come out with AGA came out with a best practice advice update statement in which they endorsed that the tissue systems pathology-based prediction assay may be utilized for risk stratification of Barrett's with non-dysplastic Barrett's esophagus. However, this update did not address the use of p53 immunostaining. So what are the risk stratification biomarkers that are coming down the pipe? So this is the Barrett's aneuploidy decision or BAD test. This is a novel PCR-based method. It uses RealSeq to amplify genome-wide loci for sequencing to identify single chromosomal arm gains or losses. This is performed on esophageal brushings. And this chromosomal arm level scores are then integrated into a global aneuploidy score called GAS. 6 specific chromosomal alterations are then combined with GAS to give you the BAD score, and this score classifies you into not bad, maybe bad, and very bad GAS. They then, after optimizing the BAD score, they then looked at medical records for 60 non-dysplastic cases that were reviewed over a 36-month follow-up period. 40 cases were classified as not bad, and none of those progressed. 16 cases were classified as maybe bad, and none of those progressed. 4 cases were classified as very bad. 2 of the 4 progressed, 1 to high-grade dysplasia, and the other 1 to esophageal adenocarcinoma. And this is another new assay that just came out in the Red Journal this year. This panel uses DNA methylation biomarkers, and it's called EsoPredict. So the assay is going to measure changes in DNA methylation levels of 4 genes plus age. It's also performed on Barrett's biopsy samples, and this panel will classify you into low risk, low moderate risk, high moderate risk, and high risk for neoplastic progression over 5 years. They then validated this panel in 110 Barrett's patients. Most of these patients had non-dysplastic Barrett's esophagus. So if we look at these 93 non-dysplastic Barrett's patients, the 26 cases developed high-grade dysplasia or cancer on follow-up. The 67 control patients did not develop high-grade dysplasia or cancer on follow-up. When looking at the EsoPredict risk category, you can see those that scored high risk had a 21.25% risk of progression within 5 years, and those who scored low risk had a 1.27% risk of progression over 5 years. So how are we going to move these biomarkers into routine clinical practice? Well, by demonstrating their predictive performance in high-quality studies. And in fact, we do have a high-quality study that's NIH supported. It's a multi-center randomized controlled trial, which is called SERVANT. And this trial is going to look at the biomarkers, p53 immunohistochemistry, tissue cipher, Watts, as we just heard, and bad gas, and to risk stratify patients with low-grade dysplasia. These are the states in blue across the country, and the individual sites are listed with site PI. So if anybody out there has patients with low-grade dysplasia, please consider referring them for this really important study. And there's some other ongoing high-quality clinical studies for biomarkers for risk stratification of Barrett's esophagus. We just heard Dr. Cole talk about the SWOT-BE study, with the primary outcome being the diagnostic yield of dysplasia or cancer. And then there's the SCRIBE study, with the primary outcome being the development of high-grade dysplasia or cancer in an unbiased community-based cohort of non-dysplastic Barrett's patients. So hopefully within the next 5 to 7 years, I think what comes next is that perhaps we can change our endoscopic surveillance strategies into more effective ones. Thank you very much.
Fantastic. John's going to come up and talk to us about anti-reflux surgery. I'll remind the group in the room that the LLSG is going to be meeting right after this at the bar. That, if you don't know what that is, that's the Lipum Surgery Survivors Group. And John will be buying everybody Coors for that. So thank you, John, in advance.
You're welcome. Anything I can do to help? All right, well, we're going to dumb it down a little bit. That's why they brought me up here. That was wickedly smart, as you just heard. This will not be anything similar to that. What I'm going to talk to you about is there a role for surgery in this disease? Is there a role for anti-reflux surgery either in preventing, helping regress? Time will tell, we will see. Disclosures, we were told we didn't need to put up disclosures, but I did want to let people know I was accepting donations. I do have 2 kids in college, so things have been rough here for the last couple of years. So here's a list of my current donors. If you'd like to be part of this elite group, see me after this, I guess at the bar where we'll be meeting Trip. So let's start with the obvious. I know many of you attended the NIN surgery course, anti-reflux course this morning, which was absolutely phenomenal in trying to wrap our arms and understanding around this disease. But if you weren't there, the crux of it was simple. GERD is a mechanical problem. There's a problem with the barrier. The American Foregut Society and what we like to call the GERD nerd group, a bunch of dorks getting together to talk about reflux and what's causing it, published this paper in Foregut here recently. If you're not familiar with it, I highly recommend getting it. It describes in great detail what are the components of that reflux barrier, what is leading to this disease. Here is sort of a snippet of it, but clearly the barrier is both the lower esophageal sphincter and the integrity of the crura, meaning not having a hiatal hernia. Reflux is failure of that barrier. It's as simple as that. If you have a hiatal hernia, your LES is hypotensive. This is what's leading to this, and this is what's described very well in this paper. And ultimately, this is what's leading to what Dan talked about, this epidemic in esophageal cancer and Barrett's. I mean, I don't care who you are in this room, whatever you are doing to impact this disease is not working. Dan showed you this graph. I can't imagine standing up and saying, I'm doing a really good job when this has increased 600-700% in the last couple of decades. We need a restart here. We need to do something different. We need to think about this disease differently. So how can we impact this disease? What can we do to decrease this epidemic, to change the direction of that curve? Well, you've already heard from Dan and Vivek and Rhonda, and I think these are all really good methods of potentially impacting this. You know, we need to detect it earlier. We need to stratify these patients to see who's at risk for progression to cancer. You're going to hear about eradicating Barrett's from Felice. Felice also is wickedly smart, so we're going to bring it up a level after me. Listen to her. She's got some great ideas that'll impact this. But the simple thing, and again why I'm here, is to maybe think about fixing the underlying problem. Again, this is a mechanical problem. And so reflux control appears to be important in this disease. And this is not a new concept. I think sometimes we ignore it, but it's not a new concept. Sri Kamindori, a couple of years ago, published this in the Red Journal, which was a fascinating paper. Historically, if you look at Barrett's eradication, the Barrett's comes back anywhere from 10 to 30% of the time. So you're successful in getting rid of it with your ablations, but 10 to 30% of it comes back. Why? It comes back because we haven't controlled the underlying problem. And so Sri put together a protocol where patients came in and got maximum medical therapy or surgery. The end game was to control reflux here. And by controlling reflux, he was able to impact the disease. Now, many of his patients ended up getting a Nissen fundoplication to control disease, but by doing that, he showed his recurrence rates after ablation of only 4.8%. So much better than some of the other literature out there that didn't focus on controlling this disease. He also found that it was easier to eradicate Barrett's if the reflux is controlled. We've all been there, right? You've ablated this patient 4 times and they've still got Barrett's. Well, I challenge you, do something to stop the reflux, and you're probably going to have an easier time getting rid of the Barrett's. Now, admittedly, fundoplication has a bad reputation. It gets a bad rap, so to speak. But regardless of the bad rap, it does seem to help. This is not a new concept. This is a publication from our group from a number of years ago that looked at our patients with Barrett's that got fundoplication. And so a medium-sized study, I will call it, 300 and some odd patients that underwent anti-reflux surgery. Overall, we found that the regression rate of Barrett's Barrett's going away on its own was 31% if we stopped the reflux. And this was defined as patients that had to have 2 or more endoscopies to sort of smooth out that sampling error. But again, regression does occur, specifically in short segment Barrett's, if we stop the reflux. Progression to cancer, and this is probably the most important point that people don't realize. Not all surgeons are perfect. Stu, did you realize that? No, they're not, and there is a failure rate with fundoplication. And so what was almost as important is knowing whether or not the fundoplication actually worked. And if the fundoplication worked, there was a significant difference in that patient's risk of progressing to cancer. You can see on the bar graph there on the right. So just because they got a fundoplication doesn't mean they're out of the woods. And so reflux control clearly to me is important, not only in regression of Barrett's, but preventing progression of the Barrett's. And so I think this is probably one of the best studies that have come out. This is a super small study, but one of the best super small studies I've seen in a long time. This is from Ben Knight and others that had a prospective registry that they all agreed to enroll their patients in. All patients had Barrett's, all patients got anti-reflux surgery, and all patients were followed for a long time. Mean follow-up was over 11 years. Now, what was also interesting about this study is they all got pH testing to see if the fundoplication was actually working. Did it control the reflux? And what they found was that they saw endoscopic regression in over 60% of the patients. And it was much more likely that that patient would regress if they had reflux control. They saw histologic regression in 41%. And again, a significant difference in the patients where the fundoplication was actually intact and preventing the reflux. And they saw 0 patients progress to cancer. So I think here's our opportunity if we just focus on controlling what's causing this disease. Now, some patients, admittedly, are still allergic to fundoplication. Now, we do have alternatives. LINX is an alternative to fundoplication. It's been shown in numerous studies to be equal in efficacy to fundoplication, with a much better side effect profile, which I'm sure you'll hear more about, and to be a durable procedure. This publication right here is from Luigi Bonavina out of Italy that looked at his long-term results. Mean follow-up in this group was 9 years. And what he found is 9 years after the operation, you want to know what? It was still working to control reflux. Now, the concern with Barrett's, however, has been that it represented a more severe cohort of reflux patients. And so there was a lot of hesitation early on to use LINX in a patient with Barrett's because we were afraid that the LINX wouldn't control the reflux. So Luigi also published this, looking at patients with severe reflux and whether or not LINX could control it. This came out just a couple of years ago where he looked at 300 and some odd patients that he defined as having severe reflux. These were patients either with an almost absent lower esophageal sphincter, Demeester scores over 50, bad CD esophagitis, or Barrett's. And what he found was this. He compared this to non-severe reflux, and at the end of the day, there was no difference in the ability to control reflux in these severe patients. They still had pH normalization, which was the goal, at least in the Barrett's group. So it did seem to work in Barrett's, which then led us down the pathway to start using LINX in this cohort of patients with Barrett's esophagus. This is out of our group at USC where we looked at our first 67 patients, divvying them up either into ultra short, short segment, or long segment Barrett's. At our institution, for academic reasons, we have every patient come back for an endoscopy and a Bravo and biopsies, and what we found is Luigi was right. The LINX did control the reflux. We took patients with Demeester scores of 35 and brought them down to about 9. It was about an 80 to 85% pH normalization rate. We then looked at regression rates with links to see if it was similar to the Nissen literature. And surprisingly, what we found was it was. It was not only similar in many ways, it was a little bit better. And so here is illustrated the regression rate. Now, admittedly, in long segment Barrett's, you really don't see much in the way of regression, but in short segment Barrett's, we were seeing upwards of 70% regression. Even when we looked at patients that had had more than one endoscopy or Watts to smooth out that sampling error. We also found that it was safe to ablate these patients after links. It's a question I get asked all the time. But the ablation is not transmural, and so there was no concern about ablating these patients if needed after a links. We then followed up that publication with a second publication with a bigger cohort of patients. 87 patients with a longer follow-up. Mean follow-up in this group was about 2.5 years. Again, broke it out into short, ultra-short, long segment Barrett's. And the same thing came out of it. Links was able to control the reflux, and we saw a significant amount of regression of Barrett's in the short segment group. So it seemed to be doing exactly what the fundoplication was doing with a better side effect profile. And again, no patient, at least in our cohort of 150-some patients between these two publications, has progressed to dysplasia or cancer. And based on that and some other publications, the FDA earlier this year, at the very beginning of this year, lifted its precaution, meaning using links in patients with Barrett's. So to me, it's clear. Anti-reflux surgery induces regression. And I would argue it probably, if intact, prevents progression. But you want to know what the elephant in the room is? Anybody want to guess what the elephant in the room is? The elephant in the room is this publication right here that came out just a few months or a year ago, looking at anti-reflux surgery compared to medical therapy in patients with Barrett's esophagus. And they concluded from their study that anti-reflux surgery increased the risk of cancer, which just from a common sense standpoint does not make any sense whatsoever. Now, I'm not going to spend a lot of time on this, but I will tell you that it kind of pissed me off. And because of that, Peter Kyrillis and I wrote a rebuttal. Well, actually, Peter wrote the rebuttal, but he called and asked me how to spell my name, and I got on it. And we pointed out clearly that the study was flawed. It was flawed from many different angles. The patient populations were not comparable in this study, and more importantly, as I have pointed out throughout this talk, there was no ability for them to judge or determine whether or not the anti-reflux surgery was actually intact and preventing reflux. With a 30 to 40% failure rate of anti-reflux surgery and not knowing that, you really cannot make any conclusions. So I've used up all my time, but to summarize, I'm going to leave you with this. The reflux barrier is definitely the lower esophageal sphincter and the integrity of the crura, i.e. not having that hiatal hernia. It's failure of this barrier that's leading to this problem, and we've got to stop ignoring it. It's crazy to keep doing the same thing over and over again and expecting a different result. Links, I think, is a great alternative for these patients with Barrett's esophagus. It has a much better side effect profile, and again, the FDA has lifted that precaution in its use in patients with Barrett's. So my recommendations, if we want to impact this disease, if we want to impact esophageal cancer, we need to fix the mechanical issue. Thank you.
Okay, thank you, John. And I'd like to invite up the wickedly smart and amazingly talented president, Felice Knoll-Sussman.
Thank you. I'm going to come on the podium because I fear if I stand on the ground, no one will see me. So I'm elevating myself and wearing some heels. It's really a pleasure to finish off this session. And when we were deciding what the last talk would be, it was going to be something where we're going to think beyond, because that's really what a lot of what we're doing today is, trying to take what we know and then just moving it to the next level. So my talk today is on when I ablate beyond guidelines. And I want you to just look at the picture in the middle. You're not going to understand why I'm specifically saying that, but just take a good look at the picture in the middle, because it's going to come up in a talk that I'm going to use tomorrow. So, medical guidelines are not a panacea. They're rigid, and strict adherence to them may limit tailoring treatment to individual patient needs. They could be outdated. Continuation of less effective therapies can happen, and even obsolete practices. There could be resource limitations. They may require resources that are not available. That could create disparities in care to certain people in certain regions. There's variation in quality in guidelines. Some may be based on weak evidence or lack any kind of rigorous review. There could even be conflict of interest in guidelines. They could be influenced by stakeholders that wrote them, leading to biased recommendations. And we heard 2 wonderful talks today about different technologies, and what I'm putting up here is just straight from the guidelines. We cannot make a recommendation on Watts. We cannot make a recommendation on TissueCypher. And these are the guidelines that actually influence the ability for these technologies to get paid for. So in spite of all of the incredible guidelines that are out there, and I happen to be an author on the guideline for GERD, in spite of all these wonderful guidelines that are out there, we still stink at a lot of things. What do we stink at? We stink at getting the right patient in for Barrett's screening. 40% of patients with esophageal adenocarcinoma report no previous history of GERD. We stink at identifying Barrett's esophagus dysplasia on upper endoscopy. More than 50% of patients with new diagnosis of esophageal adenocarcinoma had no evidence of dysplasia on the previous endoscopy. We stink at interpreting Barrett's esophagus pathology. Nearly 75% of the initial biopsies with low-grade dysplasia are then downstaged to non-dysplastic by second pathologist. We stink at complying to Barrett's esophagus guidelines. In the GI Quick registry, 90% of patients with normal Z-lines were biopsied. The guidelines say don't biopsy those Z-lines. And what's even stinkier is that when they biopsied them, intestinal metaplasia was found in 38%, low-grade dysplasia in 7.4%, and high-grade dysplasia in 2%. We stink. This talk is about what we really do, not what we preach to do in the guidelines. So, what are the guideline-approved indications to ablate Barrett's esophagus? 1, early esophageal cancer. You can ablate. 2, high-grade dysplasia. Definitely, you can ablate. 3, low-grade dysplasia. You may ablate. The role of ablation in these different scenarios has been seen in multiple studies, including 2 landmark studies, the AIM trial and the SURF trial. I'm not going to go through those, but that's really where so much of these, guideline recommendations come from. So, fine, check the box there. What do I do, like many of us have, if I have patients who do not check either of these boxes? What do you do with those patients? Well, my treatment decision analysis is just not uniformly applied to all Barrett's patients. I view the patients in categories, those that are statistically likely to go on to cancer and those that are unlikely to progress to cancer. And then I make my decision on ablation versus changing surveillance intervals accordingly. And really what I do is I talk to my patient. I mean, you can't imagine me talking that much, could you? But I do. Talk to my patient. I listen to my patient. And I hear my patients. And that is so important in this disease. So, this is how some physicians feel about going beyond the Barrett's esophagus guidelines. It's like a hazardous cliff There's like flash floods that are happening. And they're really nervous to go beyond these guidelines. They really feel stuck in these guidelines. And part of it, there's actually a very interesting phenomenon that happens with both patients as well as physicians when we diagnose them with a pre-malignant condition. It's called the endowment effect. And basically, the diagnosis of Barrett's esophagus affects medical decision-making in ways that are counterintuitive to conventional cost-effective analysis. When you tell someone that they have a pre-malignant condition, something that might become something, it's not there, it might become something, it affects the wiring in their brains. Patients and physicians feel like they own that cancer diagnosis. They must do something about that cancer diagnosis. And really, patients so often completely overweigh the probability of dysplasia progression. I mean, we might show them the probability is 0.02, whatever numbers we tell them, that is not what they hear. They hear something akin to, I have something that's going to go on to cancer. And this creates in them a preference for removal of that adverse endowment that's built. Patients will likely choose ablation over surveillance at preferences that far, far exceed any kind of rational cost effectiveness would expect. So, who do I ablate beyond the guidelines? Well, I could tell you this is really a personalized value for patients based upon their individual clinical risk factors. So this is kind of really where it starts for me. If I have patients with a long segment, non-dysplastic Barrett's, so by the guidelines, non-dysplastic, you would not ablate them. Plus, they're young. To reduce their long-term cancer risk and to break that psychological pattern that develops in those young people, I might offer them ablation. 2, strong family history. You tell me your father had esophageal cancer or 2 relatives, whatnot, and you have long segment and still non-dysplastic, I might consider offering them ablation. Significant anxiety around that cancer diagnosis. This is like a target on the back of somebody. They carry this burden with them all the time. They have such scan anxiety of going to that next upper endoscopy, they might not actually be able to function. I might consider ablating that patient population. Presence of other high risk factors, if they are obese, they're smoking, poorly controlled GERD, and long-standing non-dysplastic, I might consider ablating them. And then, if they're intolerant to surveillance, I mean, we think, just bring them back, keep surveilling them, keep surveilling. There are patients, they can't handle doing it. They just can't, and they can't even be compliant. They don't come back, it doesn't matter, send them, no, they just can't do it. They can't do it. They can't or they don't want to. I might consider ablating them. But really what this comes down to, this is shared decision making. That is the key to this. You must talk with your patients. What is the risks? What are the benefits? What are the alternatives? You gotta talk to them, listen to them, and hear them. So, what else helps me to decide to ablate? So here's a case, 48-year-old African-American female. She's obese. She was a previous smoker. Non-dysplastic Barrett's esophagus. It's not super long, 2-centimeter hiatal hernia, on PPI twice daily. Father died of esophageal cancer. She is petrified of esophageal cancer. Did a tissue cipher on her? It's high. Based upon this high risk, score, I would upstage management to include ablation therapy, or at least a minimum of a shorter interval of surveillance in her. Another thing that is also itchy to talk about, ablation of IM segments less than 1 centimeter length. I mean, these aren't even Barrett's based upon our guidelines, right? It's not even Barrett's esophagus. Well, we have to acknowledge the shortcomings of current screening and surveillance guidelines. Short segments of intestinal metaplasia are extraordinarily common. It's most of what gastroenterologists see and likely the source of many esophageal adenocarcinomas. We now have a tool. We now have a tool for stratification of these patients. What can we do? Those that are identified at high risk of progression, eradicate them. Low risk, extend surveillance, maybe even eliminate surveillance. So, one last thing to ponder. Which factors predict a poor RFA response, and what can we do about that beyond the guidelines? Here's a couple of studies. What I can tell you about is this, and Dr. Lippman was talking about this. If you do not control the Barrett's, you don't get anywhere with ablation. It just doesn't happen, right? So there's some other things, the length, the maximal length, the circumferential, but if you don't control the reflux, I might have said Barrett's, I meant reflux. If you don't control the reflux, you will not control the Barrett's with ablation. So, for patients undergoing endoscopic eradication therapy for Barrett's whose intestinal metaplasia persists despite BID PPI treatment, I believe a trial of PCAB therapy is reasonable. So, thank you so much for having an opportunity to share with you my thoughts on what we could do beyond the guidelines. If you don't practice what you preach, keep your sermons to yourself. Thank you so much.
Felice, you want to sit here, right in the middle?
Oh, sure. Right next to my friend.
I am just chopped liver.
No, you're my friend too.
All right, well, fantastic talks. Let's put up the question again and maybe retake the question in terms, and we can please go on your Whova app and show us what you got. Sorry to make you all work so late in the day. And I don't know if we can look at the pre-test score versus the post-test score or post-talk score. So, what's that? Can't see, that's coming. Well, we changed the outcome there. There's way, as long as it continues to update. But we'll keep that up there, keep the answers coming. Questions from the floor.
I think
Hit
I'd
me.
have blayed that one.
What's that?
After I just heard Felice's talk, I think I'd have blayed that one.
Yeah.
Long segment, intermediate risk, why waste your time? Get rid of it.
I'm with you 100%. And there you go. Fantastic. Well, we'll keep looking at those. Please, questions for the group.
So I think all of these talks were absolutely fascinating, and I commend everybody for their excellence. But I'm going to make a couple of comments, in part based on somewhat for where the surveillance guidelines come from. They come from people like Don Provenzali and other people doing cost-effectiveness studies saying that it was more cost-effective to use longer intervals. Yet there's data that says if you do surveillance endoscopy 5 years in a row, that your risk almost goes down to 0. So I don't know why we don't consider doing that, because we could stop. And a long time ago, Doug Rex told us that he could find Barrett's 25% of the time if he did endoscopy at the time of screening colonoscopy. And Steve DeMeester told us that if you ask the patient if they have heartburn, you could scope them and actually get paid for it. So I don't think we have any excuse not to screen people with endoscopy at the time of the first colonoscopy, or at least ask them if they have heartburn. Now, I don't do screening colonoscopy, except when they make me. But I do ask all of my reflux patients if they need one or if they've had it. So I think this organization ought to start to tell people, to ask people who are getting screening colonoscopy if they have heartburn. And then you'll all get paid for your EGD. And we don't have to deal with cost effectiveness. Now, there are some very smart people in the Barrett's world who have been doing these cost effectiveness studies, and they have ruined the opportunity to cure cancer. So I also say it's time to stop worrying about how much it costs. Because we don't worry about how much drugs cost, we just fight insurance companies to pay for it. So I'm done. Steve's not here. He would be even more volatile than I would about this. But this is really actually very easy because we do screening colonoscopy in everybody. Originally, we made up the 10-year surveillance interval for normal. We basically made it up. And a senator from Maryland got Congress to pay for it. And then Sid gave us data. So I say we just decide that this is not the way to do it and change it.
Well, and amen. And I'll just say, for those heard my talk this morning, there's standard of care, and then we need to have AFS standard of care. So let's go out there and get them.
And I will say, Phil, what I've been doing in my practice is, yes, you can get it paid for, but the problem is most insurance companies pay 100% for screening colonoscopy. But if you do an EGD, that comes out of their deductible. So the patient becomes reluctant to do that endoscopy at the same time, but they will. But what we've been doing is when the patient comes in for their screening colonoscopy, I ask them in the office, have you ever had reflux? And if the answer to that is yes, I offer them a EsoGuard in the office while they're there for their colonoscopy pre-visit. And it takes my nurse practitioner about 2 minutes to administer that test. And then we schedule their colonoscopy 3 or 4 weeks later. We have the result of that EsoGuard back. And if it's positive, then we have a reason for them to pay out of their pocket with their deductible. And we do the EGD at the time of their screening colonoscopy. And
Accept that then, but I haven't met a patient yet who won't accept the EGD if I offer it. Just my bias.
So I really appreciate all the talks. And speaking as somebody who's followed this path, right, had the EsoGuard done, came back positive, had an endoscopy, had short segment Barrett's, I can tell you that my EHAS score went down, knowing that my TissueCypher score was 1.2. Now, that being said, there's all this technology that's available. As a AFS, can we promote doing some of this newer technology to employ for the higher risk groups? Let's say somebody who's 50 to 65 male smoker that's moderately obese. Can we say that that's the perfect patient to start doing TissueCypher on to at least squeeze down that higher risk group so that you identify those patients that are more than likely going to progress or at higher risk of progression? Do we have those kind of like guidelines that we can promote as a group here? Or do we have to wait 7 years for some type of trial to give us that recommendation?
Anybody want to tackle that?
I will. We actually have a group of 15 gastroenterologists and foregut surgeons that are currently working on a Delphi on using TissueCypher, and that paper will hopefully be published by second quarter of next year.
I'm going to unload several questions on you. Dan, you have to define, since the capsular screening is not going to be done in a surgeon's office or a GI office, it's going to be done in the primary care office, most likely. Describe the patient population that you think is their target. And number two, I think I took away from this that those who were talking about ablation were falling toward the side of doing reflux control surgically first. So I'd be interested in the situation where you have a patient you know is undergoing ablation. Do you favor reflux control first surgically or following that?
Okay, I'll tackle the first part. Yeah, I think that this test needs to be in the primary care office. And I think we need to do it on every reflux patient personally at a certain age. The holy grail that would be out there is if we could develop the technology to combine TissueCypher with a cell collection device. So then in the primary care office, they get an EsoGuard or a cytosponge, and then you run a tissue cipher on it, if it comes back low risk, you don't even scope that patient. You bring them back and do another cell capture device 3 years later or 5 years later. If it comes back high risk, then you know that you go ahead and do something with that patient and even possibly progress to eradication therapy early on. And that takes that overload of, oh, we can't do all these endoscopies that I always hear when I'm talking to GIs, oh, we can't add that volume. You don't have that volume. You're scoping the very specific people that need it the most. So I hope that we can develop that technology in the future. Doesn't exist right now, but hopefully soon.
For the
Second
ablator,
part.
yeah, go ahead.
Oh,
No, please.
Okay.
I was gonna-
I think, Casey, the answer to that is, I think there's a lot goes into making that decision on whether to control the reflux first, i.e. surgery, or ablate first. For me, if they're dysplastic Barrett's, I generally like to ablate first to see if I can at least get rid of the dysplasia and make sure I haven't missed anything along the way, and then do their anti-reflux surgery. Caveat to that is if they've got florid reflux, big hiatal hernia, I'm not controlling that with triple dose PPIs, PCABs, any combination of letters you can imagine. Then that patient I'll probably take to the operating room, fix the hernia, control the reflux, then ablate.
Do the ablators, do you have a comment to that?
I mean, I would say there's a phenomenon that happens with a patient once they're told they have early esophageal cancer or high-grade dysplasia. One is the inability to take their medications, lose any weight, stop eating things that cause reflux. It becomes remarkably easier when all of a sudden they were now diagnosed with esophageal cancer. And so many of these things that were affecting controlling the reflux starts to get better, such as compliance, right? So the reflux is roaring, and then all of a sudden they have, high-grade dysplasia. Now taking the pill 2 times a day, a half an hour before the meal, becomes easier to do. So I do agree. I mean, what we do is we have a real sit down. We talk about how important it is to get the reflux under control. If I do 3 sessions with a patient of ablation and I am not getting 50% of that segment eradicated, I am moving on to something else. It could be, PCAB, but very often our practice now, obviously, it's anti-reflux surgery. So that's how I make that timeline in my mind.
We have a patient, we talked to him on Tuesday, has had 4, was going for 5 sessions. Finally, the gastroenterologist said, I just can't ablate because this hernia is in my way, 10 centimeter hernia. I mean, come on, people. That is a super highway of reflux. Your PCAB's not going to control bile and everything else flying up there. Come on.
Yeah, very early on in the endoscopic eradication therapy journey, an experienced endoscopist realizes that reflux, erosive esophagitis, or the barrier is actually getting in the way, and that's a good time to get them to surgery or some other consideration. But in general, I agree with John. I think most of our populations are enriched populations that are in need of relatively quick treatment to be started, and surgery doesn't come without problems as well. So I think we embark on the treatment pathway first, but if the erosive esophagitis gets in the way, we move laterally to other types of help.
Hi, I'm Vinay Sehgal, a consultant gastroenterologist from University College Hospital in London. So thank you for an excellent session and set of talks. In reference to the last talk around beyond the guidelines, we would have some slight anxieties about performing ablation in patients who were not keen to commit to endoscopic surveillance to begin with, because we know that this is not a one and done treatment and they have to keep coming back for regular surveillance endoscopy afterwards. So particularly in the setting of low-grade dysplasia, that would probably cause me a bit of anxiety. I think the final thing is, you referenced ultra short segment Barrett's, and we do get a lot of controversies around whether this exists or not. You talked about low and high risk. Are you able to clarify whether an ultra short segment Barrett's or an irregular Z-line is low or high risk?
Did you get that?
I'm so sorry. I speak Brooklyn, and it's totally me. But I had a little, and I think it's really the acoustics. You have a lovely accent, but I had difficulty understanding the question.
The risk, if you've got a patient who's not keen on following post-ablation surveillance.
Oh.
Even if they had low grade, that there might be some fear about bringing them into ablation to begin with because it's a commitment cure. And then the second question was, how do you know that an ultra short segment less than a centimeter and a regular Z line, to use the correct term, and would be, or a less than a centimeter segment can be high risk? How do you make that call?
Yes. So there's so many here on the panel that could talk to so many of these things, but what I would say when you go into the conversation I have with my patient when we go into ablation is that we are attached at the hip. There really is a patient contract with these things because it does not work if they do not stick to the contract. So the conversation goes like this. We have a fantastic ability to help ablate and eradicate the dysplasia in your esophagus and really change the natural paradigm of your risk for going on to esophageal cancer. But I can't do this without you. I just can't do this without you. So if you're not into doing this, then we're better off just watching you rather than ablating you. So that's really, how I approach that. And I would say with the Z line, what I would say, I'm joking, it's truly a lovely accent, and this is, guttural Brooklyn. But what I would say is that it's a high quality endoscopy. And so there are scary things hanging in very short segments. And so we do everything, high definition white light endoscopy, narrow band imaging. We use a cap on the head of our scope if we think the person has Barrett's esophagus. We do we look up and down, retroflex position, forward viewing position, and we then do targeted biopsies, and then we do all the samples. But, if you see something. But that's how I get beyond if it's ultra short segment and we believe that it shouldn't be sampled.
Yeah, definitely. In our experience, these patients often have a visible lesion. It's just going back to basics, cleaning the esophagus, spending your time using all the tech you've got on your scope, investing in that, and often will lead you towards dysplasia if it's there. Thanks.
Great.
Can I just ask Vivek to comment on the segment length paper that Trinidad published once showing the dysplasia detection rate for ultra short segment versus short and then long and ultra long?
Yeah, so the segment I showed it in my talk. That was a 2023 publication. I think you were on it as well. Basically, the concept was to show whether the dual modality tissue sampling is equally good in short segment Barrett's as well as in long segment. And the short segment was divided further into ultra short and short and so forth. So the dysplasia yield was actually higher in both short and long segment Barrett's esophagus. So that may help a little bit to Vinay's question. But the dysplasia yield was much higher in the longer segment, which makes sense. There's more tissue to be had. But I don't know that, Vinay, that we've resolved this question of GE junction cancer. Felice is absolutely correct. We've all seen enough scary cancers in that space where actually no visible Barrett's was seen. Which is why I suspect that the vast majority of endoscopists, community or academics, still biopsy the irregular Z line on a regular basis, pun intended. But I think that question has not been resolved. I don't know that anybody knows which ultra short segment is going to produce a problem. In general, these problems are at the index examination, that is ulcer or a mucosal irregularity or a nodule or a frank cancer. I have not typically seen too many patients who have an ultra short segment develop invasive neoplasia on my watch. Phil.
So with the caveat that the way we use proton pump inhibitors in our daily practice comes from a fair number of studies from a guy I used to know well, Don Castell, and his lab. I have a question. And piggybacking on Dr. Spector's comment that esomeprazole twice a day was probably equivalent to vonoprazan once a day. And all our recommendations regarding BID PPI in ablation come from extrapolation from those data. What is it going to take, Vivek, not to bother with a BID PPI and use a PCAP? You have to answer that question before I go to Kolb and then to Schnorr. I got a question for Lipman too.
I'm sorry, what is going to take to do what exactly?
To use a
recommendation is to use BID PPI while you're ablating people.
Yeah, absolutely.
And
I think
my question is, what do we need to use a PCAB in lieu of that combination, which only controls acid reflux, BID, next year, 88% of the time. That's Speckler's paper. And I bet if you use Panto, it's probably down around 70.
Yeah, I mean, clearly the PCABs have just arrived on this.
You're not going to answer my question.
I will answer your question. What it's going to take is a miracle.
What it's going to take for you
It's
to
going to take a
change your
miracle.
practice.
It's going to take a miracle. But I think the acid suppression is not a drug alone. It's compliance, it's timing, it's lifestyle modification, it's diet,
Good, you're not
BMI.
answering my question.
It's going to take a lot. It's
right.
not an easy, it's
Okay,
going to take a
fine.
miracle.
But
You're not-
but
you're
but
not-
but a
you're not
PCAB is going
prepared.
to patients are
You're
going to be
not
more compliant on a PCAB.
You're not prepared.
I don't know
to
that.
use
It's just
these-
arrived.
Of course they are. It's once a day.
Well, you know, I mean, sorry. One.
Cole, what about you?
What's it going to take?
Yeah, what's it going to take?
I said a miracle, so.
Okay. Well, I'll say maybe the patients to weigh in on it. And if patients tell us clearly and tell the drug companies and make it clear from a societal standpoint, this is what they prefer, the once daily dosing, the non-relational to meals, then potentially their preferences may win.
Dr. Schnoller knows my answer, so just that
what
I'd
is-
use it today. I wouldn't spend a minute using a BID, PPI, and PP or ablating. I'd put them on minopercent. As simple as it could be. John, I will challenge you though that once a day catheter-based pH monitoring data cannot be used at a time when we have 96-hour wireless pH data to assume that there'll be staying power. So as good as Luigi's data are regarding lengths, they're done with a catheter. And I suggest that you go back and look at your Bravo data because you reported medians, and even if you do 2-day, you can't use an aggregate score because we don't know what each individual day means. So if 1 day out of 4 is still positive, does that mean that you've controlled reflux?
Right, most of the data I presented was 4 day. Now, not all, because we were in the day.
All 4 days were normal?
No. Listen to me. Early on in the study, everybody was still doing 2 days. So you're right. Some of those patients, probably at least 50% of them, are only 2-day studies. I agree with you 100%. If we're going to control reflux, all 4 days need to be negative. No argument whatsoever.
So in your own links data, are all 4 days controlled?
Well, I have to go back again because half of those patients would have been only 2 days because we weren't doing 4 days.
Patients, how often were the 2 days controlled? I'm not trying to diss links. I'm just trying to put in perspective what the best surgical treatment is. And it
Yeah.
would be the one that would do
All I can tell you is in that study, over 80% pH normalization, and that was defined as every day of however many days they had the test was normal. So if they were positive 1 day, they were not normal. So I think
We
have
are-
one more question that came from Huva that I want to ask the group, and then we have a lovely engagement to go to behind us. So I'm going to ask that from us, which is the question of referring a patient who comes up with a high-risk tissue cipher score, and can they be referred to anti-reflux surgery, or do you need to go to endoscopic eradication therapy beforehand because of the high risk? And what would the high-risk result do to your management algorithm? So I'd like to ask the panel that question from Huva.
So you have a non-dysplastic Barrett's that has high-risk tissue cipher. What do you do next? Is the question?
Any patient with a high-risk score. Could be low risk, could be low grade, could be intermediate, or it could be indefinite for dysplasia or low grade dysplasia that comes back with a high-risk score.
Well, I would say that the study that needs to be done, if you have a non-dysplastic high risk, is let's do a study where we perform anti-reflux surgery on those patients and then rescore them a year later and see, did the anti-reflux surgery and decreasing the reflux load change their risk score? Because I think it will. I mean, we see regression. So if we can take someone that has high risk and make them low risk.
As a guy with long segment Barrett's and a lot of risk factors, white guy over 50, I would say Felice eradicate me, and I'll go down that journey. I'll be your partner.
Oh, there you go. I mean, the first thing I would say is this. Number one, when was the last surveillance done? So we can actually do TissueCypher. You know, that study is really it's doing it over the 5 years, and typically what we say is you should only do it on a specimen that you could do it on a specimen you have banked in the past 3 years. So if this was on a specimen that was 3 years ago, I would probably even rescope the patient at that point in time and look to see if there's a lesion there already at this point in time, because maybe there actually is one. So that's just one first caveat, because people are going to start going back to their bank specimens and checking them, and I think that's something we have to actually raise up in terms of the thought process. And then you start talking to the patient. You start talking to them about what that means, and potentially it could be decreasing the surveillance intervals, or it could be consideration of ablation based upon patient preferences and clinical risk factors.
Great. So, if it's all right with the moderators, I'd like to thank you guys for a fantastic session.
Stu.
Stu. Yes.
Stu.
Yeah. You can blame Dr. Katz for taking the ball.
Anytime I'm in a group of surgeons and they applaud, I'm very happy.
If it's quick, Spectre.
No, this is quick. Actually, just in reference to your question, you know, the basic principle, if you order a test, you got to be ready to deal with
Exactly.
it.
Right.
Absolutely.
So you get a positive TissueCypher, Dr. Souza showed you, those, you know, that's risky.
Tests
you
have
better
cons-
act on that.
Right.
So, you know, whether you ablate, I would agree with the blading, but you got to do something. I don't like the just bring them back later.
I think the thrust of the question was, can you wait to ablate if you're going to do the anti-reflux surgery? You'd say ablate first. That's what we need to hear. Okay, there is another poll question that's been put on that I encourage all of you to go to. It's poll question number 4 for the session, just to get a sense from this audience about using a cap in your routine endoscopy practice. It'd be great to hear what the audience thinks of that, and we'll probably reference that in the next Barrett session coming up on Saturday. Again, I want to thank this panel.